Good morning and good evening. I'm Dr. Pang Yun Cho, and my colleague, Dr. Junior Tu, will moderate this webinar today, and welcome for your comment. Professor Nivaldo Alonso is currently responsible for the cranial maxillofacial surgery service of the plastic surgery department of the USP School of Medicine. Associate Professor, Department of Surgery, Discipline of Plastic Surgery, Faculty of Medicine, USP. He was president of the Brazilian Society of Cranial Maxillofacial Surgery for two biennial, 2000 to 2002, and 2006 to 8. He was medical director of the NGO Operation Smile from 2004 to 2011, having been president of the organization between 2004 and 2005. He is currently a member of NGO Smile Train, approved in competitions for associate professor of the discipline of plastic surgery at the Faculty of Medicine of USP in 2009. He has been a member of the Lancet Commissions on Global Surgery since 2013. Professor Alonso also has the title of specialist in the area of cranial maxillofacial surgery by the Federal Council of Medicine, and been the coordinator of the cranial maxillofacial surgery residency program at HRAC, Bauru, University of Sao Paulo, vice coordinator of the otorhinolaryngologist medical program at HRAC, Bauru, USP, member of the Global Medical Advisory Board Smile Train International since 2019. Today, we are so honored to have Professor Nivaldo Alonso with us to present the topic, Cleft orthognathic surgery. Also, two experienced craniofacial surgeons are invited to the panel, Dr. Chang Yao and Dr. Frank Chen, come from the Chang Memorial Hospital, Taiwan. So let's applause and to welcome Professor Alonso's presentation. Thank you, Professor Alonso. Please.
Thank you. Good morning to everyone. Thank you, Pang, for this very nice introduction. I'll share my screen and start the presentation about orthognathic surgery. So it's really a great pleasure to be here with you because, in the last week, I heard a lot about Chang, and I also have been there in 2016 for one of your courses, and I'm really impressed with your service and everything around Chang is always very welcome. Thank you very much. These are my disclosure about this book that I have some royalties, and I will talk with you about some thoughts about orthognathic surgery in cleft patients. So one of the first things that come to my mind is always, is it possible to avoid orthognathic surgery? This is one of the babes with an incomplete cleft lip and palate. Her name is Leticia, and we saw her for all these years, and we saw her almost 10 years after she was born. And then we look at his profiles at the age of 16, and then we realized that, yes, it's not easy to avoid orthognathic surgery, but also at the same time, we can see here in 2022, the benefits of orthognathic surgery. And one of the points that is different from the normal orthognathic surgery in patients with dental skeletal deformities is that we have some cleft palate, and one of the points is how to predict the improvement that these patients have had with the speech. So this is one of the points that changes or makes difference in orthognathic in cleft patient. And of course, we're going to see some complications about this topic, because we all know that many scars and many surgeries previously, we are not dealing with, I would say, normal orthognathic patients. So just for many other situations, for many different papers, we reviewed the literature about numbers of orthognathic surgery in cleft patients. It's very interesting. It comes from 6% to 48%, and sometimes 60% are seen in all the papers in the literature. When we look back to our database, and we only have a very specific data about unilateral cleft lip and palate in Bauru, we have around 30% of unilateral cleft lip palate patients requiring orthognathic surgery. And now we are just looking back for the bilaterals, and we are very surprised that we have a high rate of orthognathic surgery in these bilaterals is over 60%. And some of them are for cosmetic reasons, but it doesn't make any difference, but because some of these patients have not just bone problems, but also soft tissue problems, and we try to solve them with surgery. So for the first question that we started asking, is it possible to avoid orthognathic surgery? Well, the answer is maybe not, because if you look at the cleft anatomy, 2 or 3 pieces, maxillar, uni, or bilateral, and we have 2 papers from our service showing that almost 20 to 30% has absent of teeth. It means lateral incisors, sometimes molars, and all this together with ear primary surgeries, many scars very early at birth. And also, if you look at this genetic incidence of population dental skeletal anomaly that needs orthognathic surgery, associated with some ethnical problems. So then the answer for this question is no. So how can we deal with this kind of patients like this one? That's one of the points that we're going to see here. And well, the problem with the very early surgeon is we really have to do this surgery very early, but also we know that when you don't do this, there is almost normal maxillary growth. I would say not really normal, but you can see that the effects of primary surgery influences over the maxillar development for sure. And this is one of these examples where, as you might know, and all around the world in the low and middle income country, you can see patients like this one I'm going to show you. That's a unilateral cleft lip and palate non-operated. And we did the surgery, the lip repair, the palate repair, and we had a fistula. Then we have a second palate repair, and this is the occlusion of this patient. And then we look back after only orthodontics treatment. Look at the profile of the patient and the final occlusion just after only orthodontic treatment. So that's one of very important point is that we all know that cleft patients, even if they are very well treated since birth, we always can have a maxillar deficiency that can arise from intrinsic factors or previous surgery. And this deficiency, most of the time in 3 axes, is vertical, transverse, and anterior posterior, as you might see in this normal Baldwin pattern from the normal facial growth in these 3 dimensions. So, well, the main clinical findings in orthognathic surgery is always a concave profile and class 3 occlusion with the maxillary hypoplasia, collapse of dental arch, and vertical shortening of the maxilla. And this can be together with residual oral nasal fistula, alveolar gap, absence of tooth in the cleft, dental anomalies, septal deviation. So let's talk about orthognathic in this kind of patient. So we are not talking about only dental skeletal anomaly. And Well, of course, if we have well, the best way is, of course, if you have a good previous lip repair, if you have a appropriate assessment and previous treatment for velopharyngeal function, this is okay, but is not what we saw in many of our secondary cases, like pharyngeal flaps, fistula repairs, and sometimes this is needed even at the time of orthognathic surgery. Of course, maxillary reconstruction in ideal age for us is between 8 and 10 years old. And this is, it means that they should have orthognathic preparation. And this is a picture to illustrate the idea of orthognathic surgeon in cleft patient. Of course, not just in cleft patient, but in cleft patient mainly is very important, because this multidisciplinary is very important to be interdisciplinary. It means that discussion between maxillofacial surgeon, plastic surgeon, orthodontics is very important with the patient beside you. So we have during orthodontic treatment two main stages, and it's 5 to 12 years old preparation for alveolar bone graft. You need most of the time maxillary expansion, external traction, and after 12 years old, it's very important to define the right way to do this kind of treatment. Otherwise, this patient will take braces from 12 to 16, 17-year-olds. So it's very important, this definition between the surgeon and the orthodontics. This is in the first time. Sometimes you will face some very important transverse discrepancy. Like you can see, you need the expansion, and sometimes it comes like this. And in time of alveolar bone graft, you have to come back and sometimes and did another expansion. So all of this is very important to be together with orthodontics and decision of the right time to do all this orthodontic appliance. So when we talk about surgery, the planning and diagnosis is almost the same as any other dental skeletal deformity. So you have to ask about patient's complaints. We use, well, you know, many different times for the orthognathic surgery. At the beginning was plaster models, and we did a model surgery. Now we have change it to 3D virtual planning, but sometimes it's not affordable to have this very sophisticated 3D virtual planning like mimics, or in some situation we have we did our own model with the X-ray, CT scan softwares, and we try to do all these studies in these different dimensions for the best planning for the patient. Let's see how we do now in our service. This is one of my patients. We see she was a complete unilateral cleft lip and palate. She has a class 3 malformation. Then we have this software. This is Photoshop, or sometimes we use even Keynote with this calibrated picture. Then we make some measurements, and we decided how much we should move this mandible or maxillar forward. And then we use an open source software. It's based on Blender. And then we put the CT scan on this, and then we make all the movements that we need, and based on some measurements that we did on the pictures. And this is the way we used to do this. And with this, again, with the Photoshop, we make some movements in the maxillar movement, or even in the nose movement. And then we can see the final result. This, as I said, is my patient, unilateral complete cleft patient that we follow. Then this is the pre, and this is the post that we achieve with this kind of planning. So some very specific surgical things in cleft patients. Maxillary osteotomy, you can face a single piece for 1 or sometimes 2 or sometimes 3 pieces. And then for this, we have modified incisions. We have some different osteotomy lines. And we use very often oral splints to help for dam fracture and sometimes to keep the transverse dimension. And associated to this bony osteotomy, we used to have to close fistulas or sometimes to add some bone graft. And maxillary osteotomy is associated to this. And we have different phases for this. I'm going to talk a little bit late. This is at the beginning, most of our patients were only maxillary osteotomy, and now we associated much more mandibular osteotomy. And this is associated with, we have a larger discrepancy, tilting or rotation. So we always started by maxillary. Mainly when you have a big maxillary advancement. So we always consider mandible adjustment because of scars and others situation, as I mentioned before, and maxillary bone graft. Difference from the procedure, the standard procedure for orthognathic surgeons, sometimes modification in the incision, HILA for one, and as I said before, closure of nasal and palatal fistula. Oh, it is stopped. It's some block. Sorry, it's not moving forward.
Yes.
Okay. Just yes. Okay.
Okay.
So these are some of our numbers. This is with the last 4 years that we have in red. It's a pandemic situation. We really lower the number of orthognathic surgeons. This is only in cleft patients. And then, as you can see here, is we have more maxillary mandibular surgeon than only maxillary, but we still do maxillary surgery in a percentage of patients. And also we have unilateral complete cleft lip more than bilateral. And you can see some numbers. And this is Renato Iaedo, one of the surgeons. We have 4 surgeons in Centrinho. Centrinho is one of the centers that do cleft lip and palate in Brazil. And I'm the director of Craniofacial there. So, and here, let's see some of these cases. And I look for some small situations that can show better the problems in cleft lip and palate orthognathic surgery. So this is a very old patient. As I said, between 2000 and 2014, most of the patients were only maxillary advancement or maxillary surgery. This is a hypoplasic midface. You can see the preparation, and this is one of the points that sometimes is a decision that should be made between the orthodontic and the surgeon. As you can see here, the missing teeth in the cleft side, preparation for surgery, and just orthognathic surgery in 2 pieces. And then in this case, we close the nasal floor and the oral floor for a 4 millimeters advancement and lowering in 2 millimeters and bone alveolar bone graft. As you can see here, it's very important to show you the oral rehabilitation in this case. And this is something that's very important. This is the profile just after the surgery. And then let's see some patients, each one with trying to show the example of difficult situations in cleft lip and palate. So this is a patient that come to us from another service for treatment. And then she was arrived at 11 years old. So the first thing we do is always the alveolar bone graft. And you see some difficult problems here, like you can see this root of the incisor root that is distorted, and then during the preparation and that was during expansion and try to put all together, we lost the central incisor in the cleft side. And also there was a missing left lateral incisor. And then here is at age 18. That's we always prefer to do surgery between 17 to 20 years old, but for some very extreme and severe discrepancy, we used to do at the age of early age, or even for women at 17, 16, but in her case, 18. And this is how we plan in virtual dimension. We have two plannings for these patients. We decided that maxillary was the problem, and we should advance it more than 10 millimeters in this case. And at the time of planning, we always have two plannings for the same patients. Just because of the number was over 10 millimeters, then we decided to also have a intermediary splint for her, and move not just maxillary, but also mandible. So we go to surgery with two different planning. And there are some when you decide to move 10 millimeters, there is something that is very important. The pterygomaxillary separation is done very gently, and we try to minimize the incision from canine to canine to preserve the vascularization of this piece of maxillary. And following this, one of the very important points, we do not use Howe forceps before we have a down fracture. And after down fracture, we try to be very careful, moving forward this maxillary with some retractor from posterior to anterior, trying to avoid some kind of movement for two reasons. One of them is because we do not need inadequate lines of fractures in the maxillary. And the second is because we know that this sometimes after alveolar bone graft, you can break this piece of maxillary. So it's sometimes when you don't have a good alveolar bone graft or no bone graft, we use a splint for this mobilization. And at the end of this mobilization, then we can use the Rowe forceps when you have a maxillary completely free. Now, here you can see in this case, we put alveolar bone graft, and you only did the maxillary advancement, as you can see in these pictures. And then occlusion pre-alveolar bone graft, after alveolar bone graft with the missing central incisor and lateral incisor. And this is the final occlusion. And this is, again, the very important point for a final good cosmetic and functional result. The oral rehabilitation is one of the points that is very important. As you can see here, looks like that the central incisor and the canine are there now have a different aspects showing the importance of this. Of course, the challenge preparation for cleft is bilateral for cleft orthognathic. And you can see here is one of the patients that have this pre-maxillary and then alveolar bone graft and some orthodontic preparation. We end up in like this, in this lack of transverse diameters. And then, but at the same times, after alveolar bone graft, you have a single piece of Lefort one for bilateral. Then you can have a, we prefer most of the time to do expansion in these cases, and then you can see the preparation for orthognathic surgery. And then you have a movement of only one pieces orthognathic surgery. And in these cases, there are very few important preoperative important issues. Of course, the palatal scars and looking at the vascularization of the maxillary. And that's very important to have this previous evaluation. But one of the points for this bilateral is the speech. You know, the speech evaluation pre-surgical. Like in this case, if you can hear, we have recorded the speech, and it's Portuguese, of course, and it's normal, and also the velar movement of this patient is a very good one. So why I'm saying this is because we always look for predictors for velopharyngeal incompetence. And this is something that's is very interesting. When we have no hypernasality, no speech disorders previously, compensatory articulatory disorders, and you have good intelligibility. So these are predictables or predictors, factors for good speech. So when you look at some of these predictors in the literature, we have one of these papers is from our unit, as you can see here, and we study 52 patients, and no matter how much we advanced the maxilla, we saw that the velar mobility was the most important factor to predict the velopharyngeal dysfunction in these cleft patients. It's very interesting because when you go to the literature, there are so many papers about this, and one of them is from Boston and Bonnie showed that if you have a short palate and a measurement of a lengthening of the soft palate or the pharyngeal, then you have in these cases high of velopharyngeal incompetence. But at the end, one of these most recent papers, 2020, we show that still there is some points that are in discussion. One of them is that maxillary advancement or gradual maxillary advancement versus LeFor-1 they have no statistically significant difference. And still, in summary, they show that effects of maxillary advancement or on the speech remains controversial in cleft lip and palate. There is so many reflections saying that this is always present. So this is some of steps in the intraoperative. I supposed to have a video, but there is some problem with the video. In this patient, showing the splint and the bone graft, and then we can see the patient here in the postoperative, and they're still waiting for rhinoplasty. But one of the points that is seen in many of these bilateral cleft is the profile of this patient. Look here, the dental skeletal after maxillary advancement, and it still have some projection at the lower lip. And what we saw is like was previous published is that some of this patient needs some soft tissue work in the lower lip, that because most of the patients with bilateral cleft lip palate also have some lower lip deformity. So there's another different situation is when you have a, like in this patient, she had a palatoplasty, primary palatoplasty at 3 months, secondary palatoplasty at 1 year, and then pharyngeal flap, and still she had a fistula in the hard palate. So here is the decision is not to do the correction of the fistula. So we decided to do orthognathic first, and for this was very important to do a speech evaluation first. And associated to this speech evaluation, we also have studies, because this is very important for us to decide when you move maxillary and mandible. This is lip studies in her case was very important. So you can see intermediary stage with preparation for orthognathic surgery. And in her case, we have some very interesting points. As you can see in the video, she has a pharyngeal flap. And this is a very important point for the anesthesiologist. So the discussion how to do the nasal intubation with the nasal endoscopy, or even in some situation that I had one before is there was some problem to intubation, and then we could have an option for submental intubation, but we decided just to cut the pharyngeal flap, and then was easier for the anesthesiologist. It's not unusual. It's not an unusual situation, I have to tell you. But we follow the patient that we made resection of the pharyngeal flap for intubation, and nothing happened. And we do not need to redo the pharyngeal flap. Oh, but this is not very often, fortunately. So this is the patient, and then for her was planned to have a late fistula correction. And it's very interesting, after mandible, after maxillary advancement, we have a post-operative polysonography. There was a real improvement after maxillary advancement. As you can see, the decision was maxillary advancement associated to chain advancement at the same time. So the occlusion before and after. And for some patients, like without previous bone graft, like this patient, 16-year-old, decision was bimaxillar because of the mandible deviation. And also, for some reason, we did not use alveolar bone graft previously because of her age, and decision was to do maxillar two pieces as in preparation. And one of the decisions that orthodontics with us was to put the canino in the position of the lateral incisor. Then you can see here, so difficult orthodontic previously. Then in this case, we always use the same internal palatal splint. And of course, in some you know, when the arch are not well coordinated, sometimes we can use these bars in the middle of the palate to be sure that the transverse dimension of the maxillar was kept. And as you can see the profile, and of course, she had a lip repair, a previous lip repair. And this is the occlusion pre-orthodontic, pre-surgery, and the end of the final occlusion. Another topic that's very important is rhinoplasty before orthognathic surgery. This guy came for a secondary rhinoplasty because it's unilateral cleft lip and palate with previous rhinoplasty and previous secondary cheiloplasty. So when we make all the examines for him, and we saw that we decided that we will not do another rhinoplasty for him. So the decision was orthognathic surgery. And again, like was saw before, the line of the incisions were using the fistula and the area of communication between oral and nasal cavity, and use this incision also to close the nasal floor. And that is the end result that you can see here, the maxillary mandible and surgery before and after. And then we did rhinoplasty with, I would say, a better improvement for his nose just after orthognathic surgery. Well, again, this is a 26 years old, a secondary patient came to us. She was repaired in our service, and the decision was to repair the lip previously, repair the fistula previous, because you can see here, there is no premaxillar. For some reason, she lost premaxillar, maybe in the primary surgery, and have an open anterior open bite, as you can see, but not just the open bite. You can see two fistulas in the palate. And then the decision was to do orthognathic first. And then she had a VPI present. So palate was so short, and there was no velar mobility. Then decision was bimaxillar for her, as you can see here, just after mandible setback and maxillary advancement and alveolar bone graft. As the CT scan can show you just in the post-operative. And then after the maxillary surgery, we came back and closed all these fistulas with buccal flap, and we did a palatal elongation, and also we associated to this a pharyngeal flap for velopharyngeal incompetence. So this is the speech just after the surgery. You still have some mind hypernasality and some disorders in the articulation of the speech, but she has a very good intelligibility, as you can hear in Portuguese. She's talking. It's of course, Portuguese, but you can notice that there's a good. And at the end, we decided to make the lip repair, like an AB flap, as in a very different situation than as evolution of her in this situation, just after maxillar advancement, mandible setback, and also lip repair. Occlusion, after orthognathic surgery, and the final occlusion with some dental rehabilitation here. Well, sometimes it's not as difficult as that one, but the problem is sometimes is how to take care of this situation. As I would say that is sometimes is so difficult, the decision not to do this for many reasons. The main reason is the vascularization of this premaxillar. So we can see here, we try to do this closing before, but we still was a fistula, anterior fistula left, and it was so difficult to correct this fistula and then think about orthognathic surgery. So then we decided to move the pieces of maxillar to the position. We kept this splint for more than 2 weeks in place, and sometimes it was left there for 4 weeks, as you can see here. And then we could close this fistula. And as well, we have this profile, and still not the best one, but the best one that I could achieve. And this here you can see the final occlusion, and the fistula was closed, and then she still needs some rhinoplasty. Well, sometimes this situation is worse because the lip repair was not good enough for mobilization of maxilla. And here you can see there was the prolabium that is attached to the gingiva in this case, therefore some problems. And then we decided to do lip repair first, because we knew that orthognathic surgery with this situation, I mean, the lip repair would not be possible. Then you can see here AB flap upper lip reconstruction, and also gingival labial sulcus reconstruction. And you can see preparation, and then orthognathic surgery closure, fistula closure, and bone graft at the same. Then this profile was before AB flap, after orthognathic surgery, and after rhinoplasty. And here you can see view, and this is the occlusion pre and post-operative with some improvement, not really that what we used to have, but that's of course we have some complications, and this is one of our complication, and she has a bilateral, and most of the complications is related to bilateral. Is we saw that could be a problem for this patient with this bad central incisor. We decided to keep it, but was not a good decision. And then we have a buccal-nasal fistula, hard palate fistula, no bone in the right side. So this is the preparation for, and during preparation, we could see that the central incisor was not good enough, and we decided, and it was not a good decision to keep it. And then preparation for maxillary advancement, mandible advancement, and then you have just after post-operative. And this is what happens is in 3 months is we lost the premaxillar with these two central incisors. Then we, of course, we came back and put some alveolar bone graft there, and then AB flap, because this is very interesting to look at this picture. Is AB flap just after the reconstruction, and not at the same time as bone graft. a time after bone graft, then you can see late some improvement after rhinoplasty and is still waiting for oral rehabilitation. So relapse. So we saw many. I don't have the numbers here now, but we are working in a paper with this number. This is relapse is present when we advance more than 6 millimeters, and you associated with some occlusal plane rotation. And this is very interesting because when you have to move maxillar to correct the vertical dimension, that's most of our recurring relapses. We have around, it's a very interesting paper that's not here, that we have much more vertical relapse than anteroposterior relapse. And I'll come soon some data about this. And some final comments. I think I'm on my time is, well, always LFR1 is the best situation. We try to always do alveolar bone graft previously between 8 and 12 years old. And sometimes when I have difficult cases, I prefer to do alveolar bone grafting before orthognathic surgery. And it depends on the situation. In private, sometimes it's not possible. In public services, more possible than in private. It just depends on many different situations. But I try to always perform rhinoplasty after orthognathic surgery. That's I know that there are some surgeons doing rhinoplasty at the same times. I really do not like to do orthognathic surgery, maxillary advancement, and then do rhinoplasty at the same times, because there are always some changements in the position of the nose, tip of the nose and base of the nose. And we have a high rate of orthognathic surgery for bilateral cleft, regardless of the lip and palate repair techniques, and mainly in our service is not related. Well, it's related to the surgeon. Of course, there are some surgeons that have a high rate than others, but always at the end the high rate of orthognathic surgery. VPI is something that is still in the study, because the numbers that you saw is 52 patients. So now we are trying to have a bigger series. But what we really can say is, when you have previous compensatory articulatory disorders and hypernasality, for sure it will increase. But when you have a very good velar mobility, it doesn't matter how much you advance the maxillar, we will not have hypernasality or change or important changes of the speech. Destruction osteogenesis, I did not show you some cases, but we use destruction osteogenesis in very large discrepancy. But it makes this, we change this for like a pre-orthognathic surgery. Most of the time we do destruction osteogenesis for more than 15 millimeters. And in this case, we came back, put plates and bone graft, and then do mandible if it's necessary. And for these patients, for reasons of many scars, and also for these big discrepancies, these large discrepancies, we always use external device. So at the end of this, I would say that cleft patients present anatomical changes, and these are very important to take in your planning. And this is sometimes related to previous surgery, but also there are some intrinsic factors involved. Alveolar bone grafting for me is one of the important procedures to get success in orthognathic surgery. Meticulous orthodontic planning, like involving dental abscess, oral nasal fistulas, and bed alignment, is very important for this kind of patient. Is a little different from the dental skeletal deformities that at the beginning we used to do, like maxillary advancement without previous planning, And now we know that for cleft lip and palate, this is not adequate. Operative technique must be adapted, like as I said, mucosal incision, fistula treatment, soft tip restriction, and limited advancement. And complication is for us is we have a very interesting experience in orthognathic in low and middle income country. Like we have a very interesting program in Morocco that we used to do orthognathic, and sometimes we don't have this close relationship with the orthodontics. And in this case, sometimes we need to do in two stages. I would not recommend this for a service like yours, that's one of the most famous orthognathic service, but sometimes I do a maxillary advancement, and then I come back in next year and do maxillary and mandible advancement, because in this case, it's orthodontic previous treatment is not okay, and sometimes you don't have arch coordination, and then it's sometimes it's done in two stages. Again, I would like to thank you for this very important opportunity to show you some of our experience in this field. And I know for sure that you have a huge experience in orthognathic surgeon, and we can. I'm a hope to have show some experience and learn more about your experience too. Thank you very much for your attention.
Thank you so much, Professor Alonso, for the very comprehensive lecture and also for the very beautiful results. Now, I'd like to first invite our panelists for some comments. Now, if you have a question for Professor Alonso but have yet to write it down in our chat room, please do so now so we can answer them during the Q&A session. Now, for the first panelist, I would like to invite Professor Chen-Feng Yao. Professor Yao?
Hello, Professor Alonso. I'm Dr. Yao in Chang Memorial Hospital, and I have first question is about the pharyngeal flap. So I have a question that for those who have pharyngeal flap, if you are doing maxilla level 1 advancement, do you need routinely divide the pharyngeal flap, or it's not a problem? Thank you.
Oh, thank you for your question. No, it's not a problem. It's just I said only one case I have to cut the pharyngeal flap, and for that's a very interesting, because at the beginning we're so concerned about pharyngeal flap, but after many cases with pharyngeal flap, we don't have any problem. I mean, even for maxillary advancement, as I show you, 10 millimeters or until 10, is okay. After that, and it's much more. I'm much more concerned about the scars on the palate than in the pharyngeal flap. It just this is more problems for us.
Okay, thank you. And sorry, and I have another question is about the alveolar cleft. So, would you prefer doing if you have a case with alveolar cleft and who need a two-jaw surgery, would you consider repair the alveolar cleft first, or you will prefer do it at the same time with two-jaw surgery? Thank you.
No, I do not prefer to do in the same time of the surgery. I prefer to do previously. But the problem is sometimes you face situations that you are not allowed to do. The decision is to do the orthognathic first. And we lost some alveolar bone grafts when you have a big or wide cleft, and you do not move the maxilla to close this gap. So then we have to come back after orthognathic surgery and redo the alveolar bone graft. And this is the situation that I try to avoid. And even in the operative field, when I look this wide gap and I have some problems with closing the nasal floor, closing some places. So I prefer not to do alveolar bone graft, because even I try many times, but I'm not succeed 100%. I try to close the palatal fistula and the nasal floor of the, and in the same operative, but sometimes it's not possible because it's you know, the soft tissues is so difficult to close, mainly in the nasal floor. But I prefer two surgeries. You know, if I could, I would do alveolar bone graft in an 18, 19-year-old cleft patient, and then 1 or 6 months or 1 year after do a orthognathic surgery.
Okay, thank you. Understand.
Thank you, Professor Yao. And for our next panelist, I'd like to invite Professor Frank Chang. Professor Chang.
Yeah, hi, Professor Alonso. I'm Frank Chang from Chang Memorial Hospital. Very nice presentation and a very nice picture. Congratulations. I have 2 questions. The first question is 1 jaw or 2 jaw. I know many centers only do 1 jaw, and I saw most of your cases are performed 2 jaw. So do you have any percentage that you do 1 jaw or 2 jaw? And what's the rationale?
Well, the rationale was a learning curve, you know, because at the beginning, like I start doing orthognathic surgery with wires, you know, and plastic model and surgery. And then at that time, we prefer to do only maxillar. And the rate of relapse was higher than now. And now we you know, for cosmetic reasons, is one of the main things is because, you know, before having a very close in touch with orthodontics, sometimes if the mandible, the midline, mandibular midline was deviated 1-2 millimeters, that was not a big problem. I advanced the maxilla and I was okay. And then there was some small deviations, some asymmetry. But now, not just patients, orthodontics, everybody's looking at you. So we are much more precise and looking for better results. And cosmetic is one of the points that make us come back to or change it for this. Or the percentage of this is like is increasing year by year. So it's much more often now to do maxillary and mandible than maxillary, but I don't have the number exactly in my mind, but I show you some numbers. We stopped for 2 years during pandemic. We came from 150 cases a year to 40, 30. And then now we're coming back and most of the cases are always maxillary and mandible. I would say if I could is around 6 to 7% is maxillary by maxillary now, but not before 2014.
Yeah, I think you are right. Two jaw has better cosmetics compared to 1 jaw. And the last question is, I saw that you, after maxilla advancement, you put a bone graft over anterior maxilla to increase the stability. Do you routinely do that, or you just do it with large advancement? And where do you harvest the bone graft from?
Okay. Well, if I have like a small advancement, as I saw you, I show you in one of the very first patient, I put bone graft, but was in the cleft, in the alveolar cleft, not in the maxillar. But the only when I don't have a very good bone contact, then I use alveolar bone graft. Usually after 6 millimeters, I like to put bone graft. My donor site is over iliac crest, because at the beginning I start to use cranial bone graft, but it's not is not functional for the operating table. You know, I was trained in a place where they use cranial bone graft for everything, and there was a French maxillofacial surgeon, Jean-François Toulane, and many other them used a lot of cranial bone graft. At the beginning, I came back and I used cranial bone, not now, because it's not functional. I mean, I'm doing a maxillar and someone is taking some iliac bone graft from Krista, and then that's what I prefer. I now only iliac bone graft.
Okay, thank you. No more questions.
Thank you,
very much.
Professor Chang. And I know Professor Lowe is probably tired from the mission, but I still like to invite Professor Lowe to say a few words for us.
Yes, Dr. Alonso. I enjoyed your presentation. This Cleft orthodontic surgery, very interesting and very good result. And I'd like to congratulate your outcome. And I found that you do have many difficult cases from the presentation, and at the end you could manage that the patient had a rather good result. So I believe that you have a very good orthodontist to work together. And this is a very good point that as a surgeon, even though we do a good job in surgery, but we still need to have a good orthodontist to maintain, to proceed, and to finish the work. So you may tell us how to maintain a good relationship with orthodontists through your surgical life.
That's the most easiest question. Thank you very much, Lu. But you know, first of all, I will just try to make clear. I know that you have the largest experience in orthognathic surgery in the world. I mean, for sure, you are the best service in the world. So I try to bring my most difficult cases to show you some solution for the cases. But about the orthodontics is a very interesting story, because the Centrinho, you know, the Cleft Center is in a dental school. And at the beginning, they hired the surgeon to do the cleft lip repair and palate repair. And they did not allow us to do orthognathic surgery. And I'm plastic surgeon. So I was trained as plastic surgeon, a craniofacial, and I used to do major craniofacial cases. And then when I started there, they said, no, you cannot do orthognathic surgery. So I said, no, and then I will not treat your patients, because, you know, mainly most of these unusual cleft, trichocolons, hemifacial microsomia, and then at the end, they said, okay, you can do orthognathic surgery, no problem. And it's funny, because still now there are 4 oral surgeons. I'm the only one, and now a second one that was one of my fellows that is doing orthognathic surgery. That's not a dentist, not oral surgeon. But the orthodontist is, we have like, in this center, we have 8 surgeons and 57 orthodontists. And this is the point. That's the most important thing. It's sometimes, of course, the primary surgery is the key for the success of any kind of treatment or cleft lip and palate. But also during this success, you need orthodontists. And the number of the orthodontists is much larger than the ones. In Sao Paulo, because I work in 2 different centers. In Sao Paulo, the orthodontist is a very close friend of mine. So that's the key point, is become friend of your orthodontist. Invite him to have dinner in your house every time. That's the only solution I can teach you about this. That's very interesting.
Well, maybe another solution is that a surgeon can marry an orthodontic wife.
That's it. I agree.
The other question is that I saw that several of your patients had very poorly repaired lip and palate before, and poor oral hygiene, and very difficult situation. And And I also saw that at the end of the treatment, they become really nice. Okay, dental occlusal relationship, lip and nose. I guess these patients are from the rural area. Okay, if you wish to finish the whole course, that may take maybe 2 years, 3 years, or even longer. That they keep coming back. How do you manage to help these patients that could come from rural area with very poor economy to receive the treatment?
Well, this is a very good question. You know, we have two different situations, or maybe three. In Bauru, there is social workers that are very good. It doesn't matter where the patient came from, because they have some support for them, some funding, some local stay for them, and they keep calling patient back to see the long-term follow-up. But in Sao Paulo, where is a larger city, and social works are not that good, and life is too expensive. So most of these patients, we lose them, you know, in a long-term follow-up. And so this is a big problem. You are right. But we have a very interesting experience in Morocco, as I said you. I just saw Gulan is here. He was there. And the orthodontists, they have a lot of problems with oral hygiene. And what we saw there is we have a high rate of loss of alveolar bone graft. We have a high rate of relapse. So this is mandatory to have a good oral care. And we saw this in the final results of numbers. So how to take care in a low and middle income country is so difficult, because if this patient came from different places, I remember the last time in Morocco, they have a toothbrush made from some kind of wood and some. So this is a really a great point. And I think that if you do a very good surgery, you do not have a post-operative care in oral hygiene and all the others important care. So then you're gonna sometimes lose your patient. So there is no good answer for your question. I think your question, but yes, I can tell you that there's three different senses how to deal with this, but it's very important. I think one of the most important things.
Okay.
Thank you.
Thank you for your answer. I do have one last minor question that you mentioned that the velar mobility can predict the postoperative speech status. Am I right? And if you detect the patient before the surgery, velar movement either is good or no good, will you change the orthodontic the surgical plan for the maxillomandibular movement?
No, the answer is no. I will not. But it's a very important question, because you have to discuss this with the patients and the parents, because they are so frustrated when they after working hard for many years and achieve a good speech. And then after orthognathic surgery, they become hypernasal. So they become so frustrated. And then sometimes they are so happy with the final result, but they are so upset with you about this. So the only care I take is talk to the patient and the parents about this, because this is a very interesting predictor. Unfortunately, we have not a large number. It's only 52 patients, but that was very interesting, because we try to correlate this mobility with the maxillary advancement. It doesn't make any difference if you advance 4, 6, or 10 if you don't have a velar movement. So, but I think it's for me, it doesn't change the planning. But of course, if I can achieve a good result, advance it less, but because of the result of this paper, now I don't change anything. I do what I have to do and just talk pre-operative. Thank you, Lou. Thank you.
Thank you very much for your answer, and I do enjoy your talk. Thank you very much.
Thank you.
Thank you, Professor Low. And I see that Professor Fayaz is with us. Professor Fayaz, would you like to say a few comments?
Yeah, hello, Dr. Alonso. Nice to see you again after 2-3 days.
Thank you. It's my pleasure.
And my question is again related to the pharyngeal flap. And you told me that one of the patients you had to transect the pharyngeal flap and you did not reattach it. What is your experience in patients who have undergone pharyngeal flap or sphincteropharyngoplasty? When you advance the maxilla, how much percentage of the patient they become hypernasal again? And what is your protocol to manage those patients?
Well, first, there is a very, very good question, Fayar. I'm really impressed with your skills in doing fistula closure. And thank you very much for this last week together that I learned a lot from you. But the answering your question, yes. Oh, well, we have many very interesting situations. Now, this year, we changed protocols. We are not doing pharyngeal flap anymore. We are starting to do buccal flap to correct velopharyngeal incompetence. And this is one point. So, and I will see in the future if this is better than pharyngeal flap, because when you do buccal flap, you really put scars on the palate, and I'm not 100% sure if vascularization is going to be the same. But we change protocols because we have a large series of pharyngeal flaps in patients that have been following for more than 40 years old, and the rate of obstructive apnea is high in these patients. It means that we have to cut some of these pharyngeal flaps. So based on sleep studies, I can tell you that some of these patients that have pharyngeal flap cut, nothing changed in the speech. If they are older, like 40, 45 years old. And the second question was about transect the pharyngeal flap. As I said, in orthognathic surgery, I have only one case because the anesthesiologist could not intubate it. And then the decision was cut the pharyngeal flap or do a submental for orthognathic surgery. I do not like submental intubation for orthognathic surgery. I really do not like it. And then only one case I transected it for orthognathic surgery. And what happens is we are so surprised in the post-operative of this patient that nothing happened. The speech was the same as before. So it means that maybe you can do not all cases, because as I show you one of the patients, she had a pharyngeal flap, a fistula, and also VPI. So it means that the pharyngeal flap most of the time does not mean that the speech is solved or the speech is good. So for this reason, I have to tell you that I don't know the right answer for you, because if I transect pharyngeal flap for treating obstructive apnea, what we saw is numbers that improve. I don't have the percentage of this. Most of these papers, as I mentioned before, the center has speech therapists, dental school, then speech course, and all of them, they keep doing long-term follow-up, but most of the papers we only saw when it's published. We don't know if it's my patients or their patients. We just know that they study them, these patients, long-term follow-up. So I don't have numbers to tell you about this, but I thank you for your question. But this pharyngeal flap is maybe no longer the best solution for VPI, as I think.
Thank you.
Did I answer your question? Because I move
Yeah,
around.
yeah,
Yeah.
yeah. Thank you.
Thank you, Gulan.
Thank you, Professor Fayad. And now I guess we'll move on to our Q&A session. So I think we have around 3 questions for Professor Alonso. The first one is from Dr. PCN, and the question is that for a bilateral cleft patient with no previous alveolar bone grafting, but has a large defect between the incisors and canines, is it safe to do a 2-piece osteotomy of the maxilla, or will that cause a poor blood supplies leading to necrosis and non-union?
Well, to safe is, I will say no, it's not, because it's not 2 pieces, it's 3 pieces, because you have to move maxillar, premaxillar, and you have 2 lateral pieces and a central piece. So I would say that's not the best way to treat, mainly when you have a very large discrepancy. Well, I prefer in these cases, like mainly if it's bilateral, to do alveolar bone graft and sometimes external destruction. If we are talking about more than 15 to 20 millimeters, then I prefer to advance maxillar, if possible in 1 piece. If not, then I don't have a good solution for large discrepancy in bilateral without bone graft. I don't have a good solution because, you know, there was a technique from Jeffrey Posnick that you move the lateral segments, become 1 piece of maxillar, but this is not possible when you have a large maxillar advancement.
Okay, thank you. And our next question is from Dr. Hussein, asking what's the most important thing in cleft orthognathic surgery to avoid avascular necrosis?
Alveolar bone graft previously. That's, for me, is to have a maxillar in 1 piece is one of the most important things to work in orthognathic of cleft lip and palate. And sometimes when you have scars, a lot of scars in palate, I would suggest it not happens in private sector or in very well treated cleft centers. But when you go, as I mentioned many times before, when you go to low and middle income country, one of the things that always I keep in mind is safety. It means that even for bad oral hygiene and anything I would do in stages, things like this, if I need to do orthognathic surgery. So for me, is have a maxillary in 1 piece and good palate repair. It's the main thing for orthognathic surgery in cleft patients.
Okay, and our last question is from Dr. Kiatnat from Thailand. And the question is, with modified incision with sparing mucosa from canine to canine, do you have problem or difficulty for mobilizing the maxilla for massive advancement greater than 10 millimeter? And what's your technique for that?
Well, I have problems, yes, because it's not easy to move more than 10 millimeters, but well, as I said, is after the cuts, and that's not very often, but sometimes if I have problems and I have a bad scars, and I can make an extra incision in the pterygo just behind the pterygomaxillar in the oral mucosa, another small incision, and try to do the osteotomy by that incision, but it's not very often. I would say that very few cases I need to do this, but if you have a curb instruments and a curb chingle or osteotomy, then you can do this. This is not a problem. The problem is to move forward as far as you need. So then I use like a TCA elevator and try to be gentle, and then I put the splint after all the osteotomy are done, then I use row forceps. And then I keep trying, and then I put some elastic with this splint. I put some elastic, I wait a little bit, and then I come back and do a row. I mean, 10 millimeters is, until 10 millimeters, I don't need it so much force to do this. But after that, yes, I need some kind of maneuvers, like I said, like, you know, rowing and with the oral splint or palatal splint, and then put this elastic and wait a little bit and come back. And sometimes I'm lucky that it not happens very often, but it can happen.
Okay, thank you. Thank you, Professor Alonso, for today's very valuable teachings online before the screen. I think we all participants learn a lot, no, not only from you show a lot of difficult cases and all the protocol and the sequencing, how to evaluate the patient with the cleft and doing the right decision for the surgery and how to cooperate with the orthodontics at your huge teams in Sao Paulo. So we still have a lot to learn from you as well. I think I want to invite all our participants to show your smile and with the Professor Alonso together on behalf of appreciation of today his nice presentation with us, no matter you are in the morning or in the evening. Thank you. And I will count to 3. Hello, Daniel. Nice to see you in German. Hi. Hello, Professor Handa from Japan. Hello, Professor Kachin from Thailand. And a lot of friends. Probably you are the first time to show your face. Yeah, Adori, Taka. And I will count to 3. Please give me a big smile. 1, 2, cheese. Thank you very much. And thank you, Professor Alonso, again. Looking forward to our next ICC online webinar. And looking forward to your participant. Thank you very much. See you. Good evening and a good night. Bye-bye.
You too. Bye-bye.
Thank you, Professor.
Thank you.
Thank you very much. Thank you.
Thank you, Professor.
Bye.
Thank you. Very good. Thank you, Dr. Vanna. Okay. Thank you, Professor Fayaz. Very nice. Okay, bye-bye.
I'll see you tomorrow. Bye-bye.
Yeah, see you.